So today's review, right? Question was already asked, is this slide deck available? There is a version of it available. I made some modifications to it yesterday. So this will be posted after lecture, right, on Canvas. If the only thing you study for the exam is this slide deck, you'll pass. You'll do better than pass, all right? If the only thing you study is this slide deck, will you get 100? No. There's no need to try to dig up alternative resources or anything. All of the answers to every question on the exam is from the slide decks, okay? So like there's nothing that's pulled out of like current or up to date or any of the other reference texts that are listed on Canvas. If you study the slide decks, you will find the answer to every single question on the exam, okay? There's 94 slides in this slide deck. We're not going to go through all of them because a whole bunch of them are practice questions. The answers to the practice questions are included in the notes on the slide deck, okay? So if you pull it up as a PowerPoint, in the notes section, it says what the correct answer is, okay? They don't necessarily have explanations as to why the correct answer is correct. So if you don't understand why the correct answer is correct, it might be a good idea to do a little bit of additional research on your own and figure out why that answer is right. But like I said, if all you study is this slide deck, you'll pass the exam, no problem. Okay? Any questions on that? Okay, and like I said, this version, there's not a whole lot of difference between this one and the one that's already posted on Canvas. I did make a few modifications, added a couple of extra lines, bolded some stuff that I thought was necessary for you to draw your attention to, okay? But for the most part, it's relatively unchanged, okay? So, things that you need to be aware of for the exam. So, be able to interpret your analysis results, particularly as it pertains to the various nephritic and nephrotic syndromes. Know what cells you're likely to see on your analysis, know what types of casts you're likely to see in various conditions. And to make sure I don't forget to say it later, make sure you know how to calculate an anion gap. There is going to be one question where you have to actually do math, and the formula is not provided for you, okay? So if there's one thing that you commit to rote memory, make sure, and it's in the slide deck, the formula for calculating an anion gap, okay? So be able to interpret BU and creatinine ratios, know what that means, know how BU and creatinine ratios pertain to various kidney diseases. Know the difference in the various fractional excretions of sodium, both urine and serum. You won't have to calculate that, but you need to know what does it mean if the fractional excretion of sodium is less than 1%, greater than 1%, and how that pertains to determining if a condition is pre-renal, intrinsic, or post-renal, okay? If you'll remember me stamping my foot, I think it was on the first or second day. Oval fat bodies, right? One slide. Oval fat bodies, indicative of nephrotic syndrome, okay? So remember that. There will be a question about nephrotic syndrome and oval fat bodies, okay? Here's your summary of casts, right? So remember what the various casts are indicative of. Any questions about this? Yes?
Are there any pictures in the past?
Should we memorize the pictures?
There may be some pictures of casts, but it's not going to ask you what kind of cast is this.
It's just something.
Okay, so it'll say this is a cast. It is this cast. What does this mean? Right? Okay. This is not a histology course. It's not a microscopy. Oh my Lord, I can't talk this morning. No, there's not going to be any slides or any questions that say, here's a slide of a cast. What is it? Right? Okay. Now, you might be expected to know what that is, right? That should be pretty self-explanatory, pretty straightforward, right? We've talked about oval fat bodies and Maltese crosses several times during the course of the block. So, but no, there's not going to be anything that says identify as cast. All right, so fractional excretion of sodium. Like I said, know the difference between a fractional excretion of less than 1%, greater than 1%. Know that in intrinsic renal disease, the fractional excretion of sodium is often greater than 3%. Okay, that's useful information to have. But primarily, know the difference between is using fractional excretion of sodium to say whether or not something is pre-renal or intrinsic or post-renal. Okay. And if these slides look familiar, it's because they've been pulled straight from the actual lectures, right? So this isn't really a new slide deck. It's had the pertinent slides pulled and compiled. All right, so on this slide, I did add this second bullet. So if you suspect that somebody has an upper tract malignancy, your imaging modalities are going to be CT or MRI, depending on what the patient's able to tolerate, right? And if somebody has an enhancing solid renal mass, it's cancer until proven otherwise, right? We've kind of harped on that a bunch, so remember that. All right, so for electrolytes, and there's more slides about this later on in the deck, but be able to talk about hyponatremia, and then how that relates to the urine and serum osmolality, right? So if given a picture of what a patient looks like, their sodium is this, their osmolality is this, their anion gap is this, their pH is this, what's the likely underlying condition that they have? So think about things like chronic alcoholism, diabetic ketoacidosis, things of that nature, okay? Yes?
Are reference ranges provided on the test?
Say again?
Are reference ranges provided on the test?
Yes, reference ranges are provided on the test, yeah. Yeah, you're not gonna be expected to remember reference ranges. Last bullet, metabolic alkalosis and chloride responsiveness. There is a question that talks about a patient with a condition who may or may not be responsive to chloride replacement. Okay. So if you don't remember about metabolic alkalosis and chloride responsiveness, review that. Okay. Flow chart for your reference. Okay. This will be useful on some of the questions. Okay. If you've taken notes on things that I've foot stomped on during the course of the block, you're in good shape. Okay. I've tried where I can to give you specific answers to questions that are going to be on the exam. Okay. All right, so hypernatremia. Know about diabetes insipidus. Okay. There will be questions about hypernatremia in a patient who's euvolemic, versus hypernatremia in a patient who is hypovolemic. Okay. And think about patients that are maybe suffering from chronic diarrhea and vomiting, right? And what effect that has on their acid-base level and their volume status, okay? Hyperkalemia. If you have a patient that's hyperkalemic, the first thing you do is stabilize their cardiac electrophysiology by giving calcium gluconate. first thing you do is give them calcium gluconate. Okay? But know about the other steps as well, the things that you're going to do to treat somebody for hyperkalemia. But if you're presented with multiple options that are reasonable steps in that treatment algorithm, remember which one's the first one. Okay. Hyponatremia, if they're isotonic, if their serum osmolality looks like they're isotonic, it's probably a lab error, right? And if their serum osmolality is hypertonic, think about other ions that might be present that would have an effect on their serum being hypertonic, like sugar or mannitol or other unmeasured ions. You see that I have cirrhosis bolded there. That might be a clue regarding a question that you might see regarding a hyponatremic patient. Okay. So I think alcoholism and the effect that chronic alcoholism has on someone who's hyponatremic and their volume status. Okay. Just a reminder on the stepwise approach to diagnosis. We went over this slide for several different conditions, right, in the acid-base lecture. Okay, so just remind yourself about this. And it's probably a good idea to know what these various acidoses and alkaloses look like in regards to a patient's bicarbonate level, their CO2 level, and their pH. Okay? Be careful. I have made this mistake myself. Make sure that when you're looking at the values that you're given, that you don't confuse CO2 with O2. It's easy to do. All right, make sure you're looking at the right column on their laboratory results, and don't get it confused, because it is very easy to accidentally, think you're looking at CO2 and actually see O2, and it will mess up your interpretation of whether or not they have a metabolic acidosis versus a respiratory acidosis, that sort of thing. Okay. But if you can remember this chart, if you can sit down and draw this before the exam starts and have it to reference, you'll be in good shape. Okay. And if you need that in number form rather than colored arrows, here you go. There will be questions that give you a patient, and it'll say, here's their pH, here's their bicarb, here's their their PCO2. What's going on with it? Okay. Do they have a metabolic acidosis? Do they have a respiratory acidosis? Do they have respiratory alkalosis? That sort of thing. Okay, so if you can remember this, you'll be good. Here's the formula for calculating a serum anion gap. Okay. Remember this formula. There is one question where you will have to calculate an anion gap and determine whether or not the patient has one or not. Okay. Any questions about that? Okay. Probably a good idea to know the things that cause a high anion gap metabolic acidosis. There may or may not be a question that gives you a patient that says maybe they were exposed to one of these things. Okay? So whether it's the mud piles mnemonic or the gold mark, it'll be useful. Okay? Yeah, hyperaldosteronism and the effect that it has on acid base and potassium levels. Probably a good idea to review that? Okay. You will see this diagram on the exam. Okay, there's going to be a question about renal tubular acidosis. Okay, know what differentiates between the different types of renal tubular acidosis. Okay, the answer to the question that you're going to get is on this slide. Okay. So think about which one of these things is not like the other, and that might help point you in the right direction. But if you can differentiate between the different types of renal tubular acidoses and what makes them different from each other, you'll get that question. But you will absolutely see this diagram on the exam. Okay? Know the significance of the urine albumin creatinine ratio, especially in diabetics. That will probably be useful on the exam. Okay. And in regards to how ACE inhibitors and angiotensin receptor blockers affect proteinuria, I'd review that. If you don't know the underlying mechanism of action for how ACEs and ARBs protect renal function, specifically in terms of how do they reduce proteinuria, review that. I think it goes without saying, we've talked about the hallmark lab findings for AKI a lot. There's a lot of overlap for those things. Rhabdomyolysis, reviewing that specific condition will be helpful. Okay. Be able to differentiate between the three molded conditions here, ATN, AIN, and AGN, right? If you can run this pathway, you'll be in good shape. Okay. You'll see that muddy brown casts and renal tubular epithelial cells and tubular casts are bolded on this slide. That might be an important thing to take note of. As in, a person comes in with a constellation of symptoms, and on their urinalysis, they see muddy brown casts. Think ATN. Okay. And again, fractional excretion of sodium, greater than 1 to 2%. There will be several questions about fractional excretion of sodium, or that include fractional excretion of sodium. Again, there's not going to be any slides that show you a micrograph and say, interpret this. But knowing that renal tubular epithelial cells are indicative of a tubular injury or inflammation will be helpful. Okay. Think about a trauma patient or a septic patient who may be hypovolemic. If you have somebody who's hypovolemic, what's the first thing you want to do for them? Right, you want to restore euvolemia. Right. Restore euvolemia. Other than acute interstitial nephritis, where else are you likely to see pyuria and white blood cell casts? Pyelonephritis. Okay, so remember that pyuria and white blood cell casts are often seen in infection, right? So a lot of the stuff that we've talked about in this block has been autoimmune conditions and you know, other sources of renal injury like perfusion defects. But remember, infection's still a thing too, right? We've talked about a couple of different conditions that have skin rashes associated with them. Interstitial nephritis is one of them. What's the other one? It's a palpable maculopapular rash, usually seen in children on the extremities. Enoch Schonlein purpura. Okay, remember that one. We've talked a lot about the difference between nephritic and nephrotic syndromes. Know your protein levels that you expect to see in nephrotic syndromes. Be very careful. Remember that when you're talking about a nephrotic syndrome, the protein in the urine is going to be high and the protein level in the serum is going to be low, right? Because they're losing it. It's all dumping. So when you're looking at the values that you're given, make sure that you know that you're looking at whether or not it's their serum protein level or their urine protein level, okay? And what happens to the viscosity of blood when you have low serum protein?
Less viscous.
More viscous. So remember when you're losing protein, so protein is an osmole, right? Protein helps maintain your osmolality and your oncotic pressure, right? So if you are losing protein, if protein's going places it's not supposed to be, fluid doesn't stay where it's supposed to be. So well, it's on the slide. What happens to people in nephrotic syndrome?
Marked edema.
Edema, right? What else can they get? Yes, but what's something that, okay, I heard it. Who said it? Ascites, yeah. So they may have anasarca, which is diffuse significant edema. They may have massive ascites, okay? So because that fluid, it can't stay in the intravascular compartment anymore because the oncotic pressure is altered because they're losing all that protein. So when you don't have fluid in your blood vessels, what's left in your blood vessels? Cells, right? If the majority of the volume in your circulating intravascular volume is plasma, right? It's liquid. If you're losing all of that, what's left behind is cells, which includes red blood cells, white blood cells, platelets. So the viscosity goes up. Solid material doesn't flow like liquid does, not as well. right? So what happens when you have stasis of blood? Clots. So remember that if somebody's serum protein is low, they're at increased risk of thrombotic events, right? So if you see a patient that has a significantly decreased serum protein, like less than 2.5, think about clots, okay? Know the time intervals, the latency periods between these two conditions, okay? There's not going to be any questions on the exam that are equivocal, okay? IgA is concurrent to 5 days. If it's longer than 5 days, it's probably not IgA, right? So be able to differentiate between IgA and post-infectious glomerulonephritis, okay? Know which one of them would cause a positive ASO titer. Okay. And know which one has more instances of gross hematuria. All right. So based on your interpretation of this slide, which one has more instances of gross hematuria?
IgA.
IgA. Right. What is the characteristic appearance of the renal vasculature in somebody with fibromuscular dysplasia? Beads on a string. If you give an ACE inhibitor to someone who has bilateral renal vascular disease, what's likely to happen to that patient?
Acute renal failure.
Yes, acute renal failure. All right, again, acute interstitial nephritis, acute tubular necrosis. Think about acute versus chronic causes. So what is a very, very common thing that causes acute interstitial nephritis? As a class, as a type of exposure. Meds. So be thinking about medications that can potentially cause acute interstitial nephritis. Okay, and there's a bunch of them. One of the ones that we talked about was proton pump inhibitors, but antibiotics can do it too, right? All right, Wilms tumor. When you're talking about, well, let's say Wilms tumor compared to autosomal dominant polycystic kidney disease, what's, from a physical exam finding standpoint, what's a big differentiating factor between Wilms and autosomal dominant polycystic kidney disease? I heard it. Who said unilateral? So unilateral. So if it's unilateral, doesn't cross the midline, palpable abdominal mass, and there's going to be other things about the patient that are going to push you in one direction or another. Like, who's more likely to get a Wilms tumor? Kids, right. So if you have a child who has a unilateral palpable abdominal mass that doesn't cross the midline, it's probably Wilms tumor, right? Also talking about autosomal dominant polycystic kidney disease, what do you need to be careful about, and Wilms tumor too, what do you need to be careful about when you're examining those patients? Right, be gentle, right? Because you can rupture renal cysts in somebody who has big, huge autosomal dominant polycystic kidney disease. You can also potentially rupture a Wilms tumor, and that's bad, right? So if you spill tumor in the patient's abdomen, you've now upstaged them. Know the mechanism. Okay, so we talked about how ACE inhibitors in somebody with bilateral renovascular disease can go into acute renal failure. Know what the mechanism is. Why does that happen if you give somebody with bilateral renovascular hypertension, if you give them an ACE inhibitor, why do they go into acute renal failure? Okay. Keep in mind the age diagnosis for fibromuscular dysplasia. All right. Now, would all of you sitting in this room consider 52 to be a young age or an old age?
Super young.
Young, okay, it's young. All right, they're not geriatric, okay. So if a question references a patient being young, they mean not geriatric. Okay, the question means not geriatric. I mean, we're talking 50s. All right. All right. We talked about beads on a string, right? Remember that there may also be small aneurysms is another characteristic finding in fibromuscular dysplasia, right? Chronic kidney disease. Know the indications for dialysis. Okay? And what I mean by that is know the GFR associated with a need for initiating dialysis. There may or may not be a question on the exam that says the patient has a GFR like this and pertains to dialysis. Okay. Okay, we already talked about this. Wilms tumor, solid mass, palpable, unilateral, doesn't cross the midline. Wilms tumor, right? What is the prognosis from a renal function standpoint in somebody who has medullary sponge kidney? Say again?
Pretty good.
Pretty good. Okay. They're not likely to, just because somebody has medullary sponge kidney, they're not likely to go into renal failure, right? Just from having medullary sponge kidney. Know that medullary sponge kidney patients can have recurrent calcium nephrolithiasis. Talked about that. I don't think there's anything that's going to like throw you a curveball between nephrolithiasis and nephrocalcinosis. Remember we talked about there's a difference between calcium deposits in the collecting system that are actually stones versus calcium deposits that are in the parenchyma of the kidney. There's no gotchas like that, okay? All right, minimal change disease. What's a mnemonic for remembering the patient population that's usually susceptible to minimal change disease? I think I heard somebody say it. Right, so it's kids, right? Minimal change disease is the most common syndrome in children, right? And children are small, right? So minimal change disease, small kids, okay? What's the most common cause in adults? Let me rephrase the question. Let me rephrase the question. If minimal change disease is the disease process in children, what nephropathy is the most common one in adults? And I'm not talking about underlying comorbidities. No. Membranous. Thank you. Yes. So in an adult, it's going to be membranous nephropathy. In kids, it's going to be minimal change disease. Okay. And what is the treatment for minimal change disease? Prednisone. Prednisone. Okay. And prognosis is good, right? The progression to end-stage renal disease in minimal change disease is low. Right? They may have recurrent episodes and they may need additional treatment, but the likelihood of progressing is low. Okay. All right. The presence or absence of anti-glomerular basement membrane antibodies is useful information. Where do you see it? Where do you not see it? Okay. And when differentiating between anti-GBM and good pastures, what's a big difference between the two as far as like systemic effects and clinical presentation? What's kind of the classic index patient presentation in good pasture? Hemoptysis, alveolar hemorrhage. Okay, so if you're trying to differentiate, if you have a patient that you're presented with and you're thinking, God, is this anti-GBM? Is it good pasture? If they've got hemoptysis, good pasture. Okay, think alveolar hemorrhage for good pasture syndrome. Okay. And with both of these conditions, prognosis isn't as great, right? They may progress to end-stage renal disease and they need transplant. Henoch-Schönlein purpura. Remember that there's no real definitive treatment options. So we talked about specifically in lecture that there's no evidence to suggest that putting somebody with Henoch-Schönlein purpura on steroids is helpful, right? Conservative management, self-limiting, bed rest, hydration, analgesics, bed rest, hydration, analgesics. I'll say it again, bed rest, hydration, analgesics. And then the indications for inpatient treatment are here, right? This isn't actually inpatient treatment necessarily, but it's your indications for inpatient treatment. But just remember, conservative management. There's no role for steroids. usually self-limiting, and the hallmarks of care are bed rest, hydration, and analgesics. Before I click over to the next slide, because you'll immediately have the answer as soon as I flip over to it, what are some extra-renal manifestations of polycystic kidney disease? Liver cysts, right? You may also see cysts in other parts of the body, but hepatic cysts are your most common extrarenal manifestation. Okay. So if you remember that, you'll probably be in good shape. All right, and we talked about this already, acute renal failure on starting an ACE inhibitor, particularly if they have bilateral disease, right? And remember why that is. Okay. We talked about what the gold standard is for renal artery stenosis imaging, right? Renal arteriography is the gold standard. But practically speaking, what's the more likely imaging study that's going to be done? Say again? CT. Yeah. And like it says on the slide, it provides the best images. All right, pretty much the rest of the slide deck going forward is practice questions. So we can run through some of them, or I can return your time to you and you can review the slide deck at your leisure. As soon as I leave here, I'm gonna go back to my office and upload this slide deck. Again, it's pretty similar to the deck that's already on Canvas with a few minor changes. I didn't make any modifications to the practice questions, okay? If you study this slide deck, and nothing else, you will pass the exam. Okay. If you study all of the slide decks and know them frontwards and backwards, you'll get 100%. There's no, I know, I get it, I know. That's impossible, right? I understand. But the point is, you don't need to be like digging for additional sources. All right. Everything that's on the exam is from the slide decks that have been presented in lecture. Okay. And most of what you need to know for the exam is in this review slide deck, okay, in one form or another. Knowing acid-base conditions, knowing how to differentiate between metabolic versus respiratory acidosis, metabolic versus respiratory alkalosis is high yield. Right. So when I say if you can draw that chart with the arrows or the actual values, whatever works better for you, if you can do that, it will help you a lot on multiple questions. Okay. Yes?
What about compensation? Compensation when it comes to the acids.
There are questions that talk about what the patient's clinical presentation is that may indicate that they are attempting to compensate in one form or another, but it's not asking you what's the compensation. It provides that information to help lead you to what's their actual underlying problem. Okay? Any other questions? Okay, so the exam's on Friday, so we've got several days before the exam actually occurs. If you have questions while you're studying, let me know, okay? If you don't know where my office cubicle is, I'm right back over here in, I always get it backwards, it's either 3301 or 3103, whichever one it is, B, all right? So the one that's straight back, far right-hand corner, right side. So if you know where Colonel Rogers' cubicle is, I'm right next to him, okay? If you need to get a hold of me, Canvas is probably not the most efficient way. I'm not likely to see a message in Canvas as quickly, so if you need to get a hold of me, Signal's probably the best, or just a straight up text message. And if you don't have my cell phone number, it's on Canvas on the front page for the GU block. Okay. Any other questions?
Sir,
Yes.
will we need to calculate the FINA, or it would be given like FINA?
So you won't have to calculate FINA. No, it'll tell you that the patient's FINA is less than 1%, greater than 1%. The only thing you're going to have to actually calculate is an anion gap, and there's one question. One. So just know the formula for calculating an anion gap, and if you do that, you'll get that one question. Okay. All right. So everybody's good with me returning your time to you so you can study on your own?
Okay, sir.
All right.
Thank you, sir.
You're welcome.